Well, I'm delighted to have panelists and my colleague Livia Davis here to talk to us about peers in transition roles, particularly as it relates to suicide prevention. So I'm just going to hand it to Livia to take it away.
Thank you, Katie. Good morning. So what we're going to do today, we are just going to have our panelists briefly introduce themselves, and then I will ask a couple of questions. So we're going to kind of go in turn answering each of those questions. And then hopefully we'll have some time for Q&A as well. Does that sound okay with everybody? All right. Their full bios is in your package. I'm really glad to have people from the field who are here to give us some examples of peer roles in, working experiences in peer roles. I'm going to start right here, and you can just introduce yourself real quickly.
Yeah, good morning. Karen Kiley from Beacon Health Options, and we're also known as the Connecticut Behavioral Health Partnership. We have a pretty good-sized peer department. I'm very fortunate to be part of that peer department, and glad to be here today. It's honored to be asked. We have a good zero suicide program too, which Allie Nadu, where is she, is a very big proponent of it at our organization. And I've been with Beacon about 6 years, and before that I was with the Rushford Behavioral as a case manager, and just glad to be here today.
Thank you so much. Caroline?
Hi, my name is Caroline Mazzell Carlton. I've been working in a peer role for about 10.5 years. I remember it very clearly when I started because I began the same week that I moved out of a group home that I was a resident of myself. I've worked in peer roles both in the public sector and private sector in North Carolina, but it's been an honor and a privilege to be a part of the Western Mass Recovery Learning Community for the past 7 years. And I just want to say how grateful I am to be here in Greenfield today, which is the home of the longest running Alternatives to Suicide group, I think, that meets in the world. They meet in a few different countries now. But I want to honor that lineage and just to clarify that Alternatives to Suicide groups do predate Dee Hirsch's model, which is a clinical model. It's Dee Hirsch is only, people access the group for about 8 weeks, and it's co-facilitated by a clinician. Our groups are really places, communities where people can be involved for as long as they want to. They become miniature communities, and they have always been driven and held by people who are open about their own experiences around suicide. So really grateful to be here in this part of the world where so many of those ideas took root.
Hi, I'm Paul Hammer. I'm a research associate at the Yale Program for Recovery and Community Health. I provide peer support as a volunteer through the Depression Bipolar Support Alliance, and today I'll be talking largely about my lived experience and thoughts about peer support in that context.
Thank you, Paul. Valerie?
Hi, my name is Valerie LaPutra, and I am the Young Adult Coordinator over at NAMI, Connecticut. I've been working in the peer role for about 4 years now, doing originally direct one-on-one care with the young adult population, and now I work doing more training and support in community-based work as well.
Thank you. So I'm going to start with our first question, and I'm just going to ask each of you to answer it. Paul, and again, you have a little bit of a different role in this panel, but that's okay. And you can just say, how it kind of impacts you, or you can say we can pass on to Valerie. Does that sound fair?
Sure.
All right. Okay, so the first question is, what is working well in terms of peers supporting people through transitions in the programs that you work?
At Beacon, we're very lucky that we can go out and meet people in the emergency department. We have, right now we're working, most of the program I'm in is the Adult NGA, National Governors Association, high risk, high need people. We also do regular referrals too, but the good part about that is that we are working with the hospitals, and when a person arrives, we're notified, and we can go there right to the ED, even if you hold their hand and say, it's going to be okay this time, and as a peer, with lived experience, my lived experience was I had the letter there about the suicide saying goodbye, brought back a lot of memories when I had written letters myself to my husband. And that me? And it just brought back memories of the torture I put through people that loved me and just didn't want to deal with me anymore because I caused them so much turmoil in their own lives. And we don't tell war stories to our clients that we help, the members, the Husky members, but we do make it known to them that I'm in recovery, I've been through what you've been through, and they know immediately that you're not going to be judgmental about anything they say to you, anything that they're there for. You're just there to help, even if it's to hold their hand while they're in the ED and say, you know, we can work together when you leave here. Because transition, as you were saying, was so hard because as soon as most of our clients are co-occurring with drugs and alcohol and mental health issues. And they know, as you just was said in both the presentations, is when they're feeling a little better, then they heard that they said to somebody they were suicidal, they take that statement back and they say, oh no, I was just kidding, I just felt that way yesterday, I'm fine today. And that's what happens. They go out, they leave, and they're no better than they were the day that they went into the ED. And there has to be some better way to have the staff in the hospitals recognize that and work with them more down the road in the future. I loved the respite, the peer respite. I think that's awesome. I hope that that spreads and we're able to be involved in that too. But we just make sure that the member that we work with has our number, we have their number, and believe it or not, the best thing that Beacon has allowed us to do is to do texting on our work cells. And our clients who have, a lot of them have the free phones and they have unlimited text, keep in touch through that text, even if you can touch them and say, how's your day going? And they'll answer. And if you feel that they're not doing well, you pick up the phone, you call them to get a voice. And we're able to say, do you want to meet for a coffee? Or where are you right now? And we're able to get in our cars and go. We meet them in the ED, we meet them in the psychiatric wards, we meet them in the inpatient for medical. And that's what I love about my job, is we can just meet them where they are, no matter where they are, park bench. We take the bus with them if they're nervous. We go to court with them, which is a big deal, because some of them have said, I wouldn't have come back after lunch if you weren't with me, because having been involved myself, court's terrifying. And you really, if you go alone, it's just nobody there that understands how terrified you are, even if it's to say, it's gonna be all right, it'll be okay. And I just enjoy my job. Like I said, I had the lived experience, which unfortunately was a coma, a stroke, multiple suicide attempts. And the sad part is you even get mad at yourself when you've tried to commit suicide and you didn't do it right. You think to yourself, I can't even do that right. And then your depression gets even worse because you feel like such a failure at everything you've ever tried. So I'm glad there's more efforts, and there's Allie that I pointed out before in the corner there, our zero suicide proponent for Beacon. And I just want to see that change, and the only way to change is more communication, more open, honest communication. We do some RAP planning with people too that are high risk, which just means that we say to them, do you have anybody that you can call daily and they can call you? Or somebody knock on their door if they're in a group home, if they've been up in their room more than an hour alone. Just that kind of RAP plan. I want to do more of that and spread that word that works, seems to work. I'm glad to be here. Yeah.
Thank you. So it sounds to me like not only do you go in during the emergency department visit, but you're able to continue the relationship afterwards as well.
We have people that we've been working with for years, and as you know, as from our own lives in the past, you can go up and you can go down. You go up and you can go down. And even this morning on the way here, 7 o'clock, I got a text from somebody over the weekend who got left the hospital, and just call him to say, you know, he was up early, and say, what are you going to do today? What's going on? You know, I'm glad you got out of the hospital, but what's next? You know, and he had a housing appointment today, and gave him a number of somebody who can give him a ride there.
And are you able to stay in the emergency department for as long as the person would like you there?
Yeah, the first day we don't go usually because sometimes they're so, when we call ahead and say, you know, how are they doing? And sometimes they'll say, today's not a good day to come. And we'll wait a day until they're more logical and more clear-headed. But a lot of the emergency departments, especially on the psychiatric wards we work with, we each have assigned hospitals, and you get to know the staff really well. And we also have what's called community care team meetings, where there's providers around the table, including Beacon with the behavioral contract, CHN, the medical people, the shelter people. We all sit around a table and we have our members sign a release, and You can bring their name to the table instead of we have a person without a name. And everybody around the table generally will, oh, they were to see me, oh, no, they didn't make their intake. And you just get a nice history about the person so everybody can call each other if someone's missing and you can't get them. You can go to the soup kitchen, you can go wherever to look for them too, which is what I really like about my job. You can just go. You know, anything that's supportive to our members, we just are able to just go and look for them, find them, keep them company, help them through whatever turmoil they're going through.
Thank you.
Thanks.
We'll have a Q&A a little bit later, so I just wanted to ask that clarifying question. Caroline, can I turn it over to you?
Yeah. So to kind of encapsulate the broad reach of the Western Mass Recovery Learning Community, I think I'm going to share a little bit about just one group that I was a part of last week. It was an Alternatives to Suicide group, not in this town, I'll offer. I was a part of this group, and there were people that were able to attend this group. One person who was hospitalized, had been hospitalized for 5 years, was still hospitalized in a long-term unit. But they were able to attend because this hospital partnered with the Western Mass Recovery Learning Community to ensure there's peer support on their unit. But that peer support also includes bringing people to the community out on pass, because folks are able to build these connections with folks at the RLC that maybe they can't with clinicians, and also clinicians cannot continue the relationship after this person is discharged. So we had someone at the group that was in hospital, had been there for 5 years. We also had someone in the group who was sharing deeply. This person had undergone a forced acute hospitalization and was now staying at our peer respite, AFIA, to kind of unpack, some of what they went through, some of the trauma of the forced treatment, but still to be in a place. Our peer respite it looks a lot more like a bed and breakfast than any type of institution. And so they were there at AFIA, and they were free to come to the group as well, because AFIA has no locked doors. And then there were other members of the group, some who were experiencing homelessness and came to our center for resources around that. And it was just this incredible space. It was this incredible space made possible. And what I loved is people were having these conversations where they were openly saying, I can't have this anywhere else. And there was someone who actually worked in a peer role who was struggling with hearing voices. And there was this profound moment where the person who was still in long-term hospital was able to reach out to this person and connect with them and support them with that. So it's about creating these spaces where we sort of dismantle this idea of sick and well, helper and helped, and we come together and we create meaning and community. And because the RLC has been doing this work in such diverse settings for so long, we've had the opportunity to sort of develop our own framework around how we look at thoughts of suicide in our community that's actually working really well for us, which we call the Alternatives to Suicide approach. I wish that I had more time to talk about it more, but I'll just say briefly, what this approach we use in our spaces is kind of, when we say alternative, what is it an alternative to? So first of all, it is an alternative to risk assessment tools like the Columbia. I think one of the reasons why those tools don't have a lot of predictive value is, for me, and for a lot of us with psychiatric labels, we've been assessed many, many times, so we kind of know how to answer a Columbia to get what we want or what we don't want. So in our community, what's working really well is this shift from predicting behavior, this shift from if to why. So we're focused on, why do people want to leave this world? And it's important because sometimes I'll have folks come to our groups And one woman was inpatient 3 times, had been assessed many times for thoughts of suicide, but no one had once asked her why she wanted to die. And finally, in the group, she was able to talk about that. And that was, the result. It was a sexual assault. And so this second alternative that in our community that's working well is an alternative to pathology. So I recently got married. I'm celebrating my 2nd wedding anniversary. But when I got married, I was told, don't have children. Please don't have children, by a family member. I was told, Caroline, you have a mental illness, and your husband does as well. You've both attempted suicide, you're mentally ill. So there's no hope for you to not pass that pathology on to your children. This can be really disheartening, build a lot of feelings of hopelessness. So in our community, we don't focus on internal pathology. We look at what are the other factors. So Virginia Woolf, for example, was mentioned at the beginning of the talk. Virginia Woolf, I feel like it's important to name, she was also endured years of sexual abuse at the hands of her half-brothers before she began hearing voices and before she attempted suicide. So in our community, looking at those pieces like trauma, but also lack of resources, figuring out we don't look at suicide itself as the problem, because if we're truthful, suicide is a solution. And we want to figure out what is it that you are trying to get away from. Because if we just focus on making suicide go away, we're not actually addressing the root causes that make people leave this world. And then the last thing I'll say about our community that's working really well is non-coercion. So our defining principles, we have many. They include things like potential for change, genuine human relationships, but a big one is self-determination. And it's really important in our community to take a non-controlling, non-coercive stance. Because I know for me and my colleagues, one of the things that we hear over and over again in our RLC settings from people is, I haven't talked about these thoughts of suicide in years. I haven't talked about my thoughts of suicide in months. People will typically say, I haven't talked about these thoughts since I was force committed. I haven't talked about these thoughts since I called a crisis line, and then all of a sudden these police showed up at my door to do this thing called a wellness check. I haven't talked about these thoughts since then. But what we never hear in my community, what we do not hear is, I stopped thinking these thoughts when those things happened. I stopped thinking these thoughts when the police came to my door. I stopped thinking these thoughts when I was committed. So in our community, one of the things that has worked well is to let go of some of those types of interventions. They're not used. And what we're seeing a lot more is folks having the conversation. So I could go on, but hopefully that's sort of given you a sense both of what we're doing and how we get there. What are some of the values shifts we make to create these spaces?
So
Just,
I'm in.
Paul, just a second. Sorry. Caroline, I just want to let you know that we will have hopefully a little more for Q&A because there's a lot. But for the Afia House, can you just say, just the basics of it? How long can people stay there? And then, how many people there, and maybe a little bit about that?
Yes, sure.
Sorry, Paul, just a second.
No problem. Afia Peer Respite is in Northampton. It has been there for 7 years. People stay there for up to 7 days. Everyone has their own room with a nice, I think it's queen or maybe double, a place where they can land. There is 24-hour peer support there. 24 hours folks who are trained in the alternatives to suicide approach, as well as intentional peer support. And it's a place where there are no locked doors. So if folks are staying at the respite, they can attend alternatives to suicide groups in the community and other RLC supports. A stay at a FIA is determined by the person themselves. It's not required to have any type of particular diagnosis or note from, a prescriber or doctor. It involves, if you're someone that feels like a FIA would be a good place for you to land, it just involves a conversation with one of the advocates at a FIA. If you want to learn more, there's a great 25-minute video about a FIA peer respite that contains some of the history of peer respite in general, available on YouTube.
Thank you. And I also know on your website you have more information on the alternatives to suicide groups. So
yes.
Yeah. So, and a FIA means what?
A FIA means wholeness in Swahili.
Thank you.
Yeah.
Thank you. All right, Paul, sorry.
So I'm in the process of taking peer support training, state certified training in Connecticut, but just in the beginning of that process. So I'll just talk about my personal experience as a volunteer provider of peer support through Depression Bipolar Support Alliance. And that is, this is an extraordinary group as compared to groups I've been in the past. We meet once a week. But we're constantly on the phone and texting with each other, especially if someone's in trouble. And we meet each other in person during the week. And I see that as a contrast to our mental health system, where you see a clinician once a week, once a month, in the office. It's not unheard of, but it's not common for clinicians to reach out to consumers of mental health services unless it's clear that there's a crisis. And it may not always be clear. That's the key thing. There may have been a precipitating event that is not known to the clinician. So it's frustrating to me to be able to communicate with any of my doctors on my chart, which is sort of an app Yale New Haven Health has, except for my behavioral health practitioners. And that is happening, I hear, in some places around the country, but not where I am. So that's frustrating. And so that's, to me, where peers come in. One of the things that they can do is to be there by text, as you were referred to, and other forms of communication that clinicians do not commonly engage in.
Thank you. The volunteer program is, say again, who is it with? Oh,
DBSA, that's the Depression Bipolar Support Alliance. They have groups all over the state and the country.
Okay. And the volunteer it's a program you have to be trained for.
The facilitator is trained.
Okay. Thank you. All right, Valerie?
So we have, I'm going to speak mostly on the young adult piece, but we have, with our young adult connection communities, we have groups that meet throughout the state. And what works is that everybody who goes to the group, it's voluntary. So you're not forced, you're not being told by your doctor or clinician that you have to go. And what I think works is that the people who are facilitating the groups are 2 young adults who've been trained in our model, who have lived experience as well. So being able to talk about what is it like to be a young adult in this world, going through this transition, as whether you're living with mental health challenges or just life in general. And we don't force people to talk about what's going on. So they don't have to have a diagnosis. They don't even have to know, like if they don't want to talk to a clinician, they don't have to, but we talk about within our communities, like what works and what doesn't work for ourselves. And if they want to, they have the option to go. We also do within the group's activities. So some people don't want to speak about what's going on in their lives, but they'd rather draw or write, creative write, or listen to music and play things that help them channel whatever's going on in their lives. So that's been a really helpful tool to help people feel connected and supported. And we also do like hiking, so people are doing that mindfulness practice. We also have, on the other end, we have a grief support for people who've lost somebody to suicide, because a lot of times people who have lost someone to suicide also have thoughts about suicide. So what works is for people to be able to talk about what that pain and what had happened to them and what's going on and the loss of that person. So I think what's been working is that with that transition, being able to create even personal goals, no one's telling you what your goals are, you're creating them yourself. You can do activities to promote that wellness, and it's voluntary.
How do people find out about you?
We try to do things on social media like Meetup, Facebook, Instagram. We go to events. For example, yesterday I was at Pride, so I was able to talk to people about what we do, because a lot of people who are experiencing mental health challenges, it could be as a result of the discrimination and prejudice against being LGBT. I've been trying to get into places like Comic-Con, so that way people who also can hear about us, because we know that people who don't always feel connected or they don't feel supported, we can be there to say, hey, you're not alone, and if you want to check this out, you can.
And you said that the groups are facilitated by 2 people also?
Yes.
Okay. And they're both volunteers and people?
Both volunteers with lived mental health experience, and they've been trained in our model as well.
What's your model?
Well, I kind of developed it myself, but it includes, intentional peer support, motivational interviewing, smart recovery model, all different types of like peer-run, peer-based models that work for young people.
Okay, well, thank you. And again, I have lots of questions just hearing what you just shared now, but let's go to the other question, and so we have some time to also for Q&A. So for peers who are working in this space, what support do they need in order to kind of do their job well?
I just like the passion that you can get from others, and you learn about new things that are out there. And truly, I just would love a respite system because the hostile recidivism on people who are going there, because someone either calls on them because they've expressed that they're not doing well, is you just need to go somewhere where someone understands what you're going through and they know they're not alone and that they're not odd for thinking that way. And to just have, when I was suicidal, there was no one I could call that wouldn't say to me, oh, come on, knock it off. Everybody would think that it's just not a big deal, that you could stop thinking about it. And it is a big deal, and it's hard to stop thinking about whether you failed on a plan you had in your life, or you've hurt somebody, or you think life's never going to get better. You need somebody to sit with you that understands how you can think that way and help you to change those thoughts. And that's why the respite would be so great, truly. New information, whenever there's something out there, some programs that we've been finding out through our members that we work with, they'll stumble across it in the community, like at a church or something, or a suicide group. And we didn't know about it because nothing was charged to Husky, nothing was. And so the more resources we can find that are just kind of like, little backroom things that we can give out with the packets we give out for support. And I do like the texting thing, and I think maybe some on-call stuff would be great for us to be able to do. I know some of us take our phones home on the nights and weekends, and we do check our text and everything. It's not part of our job, but we just do, because we know so we would want somebody to be open for us if we had some problems, And just very lucky to have a great department, great boss who's very pro-Husky member. Whatever you need to do for XYZ, for whatever person, you just go do it. Whatever you know them so well. And we do a lot of motivational interviewing too. That's why I love the Y. And so and it's nothing that we force on them, and we just like to be able to give whatever we think they tell us what they need. So enjoy that.
So there's partly this is an infrastructure to supervision or colleagues that support you in this role, and partly it's because of the work that you do, the why. It's motivating, and it's learning about how, from others, how they're doing that work. Is that kind of what the...
Yeah, and it's kind of a funny thing is when I was going through all my troubles, the last place I went was Rushford Detox, then inpatient, and then outpatient, and then back to groups. And when I had a year of sobriety, was involved in all kinds of groups and everything, I got a job at Rushford, and then went back to school and got promoted a few times and ended up being a case manager. And they gave me the high need, high risk clients there because they knew I would be able to, I wouldn't be afraid to talk openly and honestly with them. And that was my first job in sobriety. And then went back to school again, just graduated last year from Albertus with a bachelor's. And here is somebody who wanted to be dead. And they told my husband to unplug me, that I would never be useful in society again. So it's a miracle to be here and to be able to help other people to not have to go down that far, and that there is hope and people who can help you.
Thank you. Caroline, what do people need to really do their job well?
People need a living wage. If we want to value peer support, we need to value it financially. Peer support specialists, need to make a decent living. So that's number one. Number two, though, is please respect peer values. One of the most difficult things for me working as a peer in the system was often feeling tokenized. I was told, for example, I should never facilitate a group without a clinician, and that I should never talk about suicide. That was one of my peer roles. So it's very ironic that I now facilitate and train other people to do exactly that thing, to hold group spaces without clinicians and explicitly voice and explore thoughts of suicide. We need more funding. We need more respect for these approaches. I know, we tried to get funding actually to do like a research study about alternatives to suicide, and we were turned down, likely because, we haven't had, a lot of us haven't had the privilege of getting academic credentials. But so what we did instead was like our own SurveyMonkey, like anonymous research. And we didn't have an IRB or anything, but we did have 50 anonymous respondents, and it was really interesting. I want to share some of the results of that. There were two major. We wanted to find out why are these groups beneficial? Like, what do people take from them? Why are they popular? What do they do for people? About 96% of respondents said what was helpful about the group was that they could talk about things like suicide, but also trauma and hearing voices without any type of negative consequence or coercion. So that was number one. And number two, people thought about 94% of respondents found it powerful to be in a space where they could hear how other people had moved through dark times in their life in their own language. So these two things are sort of, being able to talk without, protocols and assessments and diagnostics, and being able to hear others' radical and transformative vulnerability. These are two huge things that people in peer roles can offer. So I think more respect for the work that's being done, that has been done, because people in these roles are often having conversations that clinicians are not, due to really big power differentials. We could be teaching you a lot of things about, about the conversations we've had. So I think, all of us in learning, having a sense of humility too. And the last thing I'll cite, in this country and every country we've brought Alt to Sue to, which is Canada and Australia at this point, it is Indigenous peoples that have the highest rates of suicide. And so people have tried to approach that by, bringing in more Western medical model treatments, hospital beds, pharmaceutical products, and it made no difference. But research out of Canada is showing that in communities where people are able to reclaim some of their ancestral languages, lifeways, and spiritual practices, suicide rates begin to drop. So much so that in communities where half of folks are conversant in these sort of ancestral practices and languages, the suicide rate drops to nearly zero. So it's far less than the general population. So I think having some humility about the limits of the Western medical model to really reduce rates of suicide. I think we need to look at impacts of colonization, of homelessness. I think it was the Wall Street Journal or the Washington Post recently published an article about how raising the minimum wage actually reduces rates of suicide. So having some humility around causes, and I think that also means looking at iatrogenic stuff. Like we've been talking here about how transitions are hard, and maybe it's the transition out of the hospital that causes those staggering rates of suicide. But I think we also need to take a close look at what's happening in some of these hospitals and be open and honest about whether, people are experiencing potentially re-traumatization, or whether, being labeled with mental illnesses is causing increased feelings of hopelessness or lack of control. So those are some of the things, conversations that I think we could be having, and involving more people with lived experience will support that dialogue.
Thank you, Caroline.
So this is somewhat speculative since I don't work professionally in the field, but borrowing from another area I do know something about, I believe that workplaces should be designed that are friendly to peers, and that may involve providing reasonable accommodations under the ADA for persons with mental health conditions. We may be recovered or recovering, but we may need special accommodations, especially under stressful conditions. So again, that's speculative, but that would be my thought as to some attention should be paid to designing workplaces in an optimal way for peers.
Thanks. Mallory?
Kind of echoing what everyone has said, even being able to have an authentic conversation with, like, if someone is a clinical-based person working with the peer, learning from the peer of what they can do to support, and also what the clinician can learn from the peer themselves, of how they can support the clinician. And also, I think that just putting peers in all different types of roles, like I know that I've been able to work with peer researchers, and they have been known to actually get more authentic data because people are more willing to talk about what's going on in their lives with somebody who has been there before. And having reasonable expectations and not tokenizing, again, too, with as a peer, because we know that there are people who are maybe working in the field that have their own personal lived experience, but they just have not openly talked about it.
Great. Well, it's a good thing this is just the start of this conversation, isn't it? That this is our kickoff, because there's so much that you already have offered. And I have some questions, but before I ask any questions, I want to see if there's somebody from the audience who have some questions. I will roll. Yep. No.
Hi, this is just a general question for anybody that has any insight or feedback. I oversee peer integration statewide in the state of New Hampshire, and we have a lot of uphill work to do, let's just say. My question is around oversight of peers in the system overall, and when I say that, we have a lot of embedded peers in community mental health centers, some emergency departments, although that should be better. What does that maybe look like in your systems, or any insight into anything that you have? What I'm talking about is like the clinical role and the peer role and how that integrates, and the supervising of peers and in a respectful manner.
Anyone want to go first? It looks like Caroline wants to. Yeah, go ahead.
The peer role has unique and important values that differ from the clinical model. Therefore, to me, it makes very little sense when I see peers that are supervised by clinicians. It causes values creep. It can be frustrating on all sides. For me, I was once being supervised by a clinician, was asked, if I needed a med change because I was advocating for a less restricted part of the unit. So I think honoring that uniqueness, if I'm a violinist, like, I'm not being supervised by, I don't know, someone that builds brick walls. It's like a terrible metaphor maybe, but like, we need the people supporting us to be well-grounded and understanding what peer support is and what its values are.
Anyone else? Karen?
Yeah. One of the things that seemed to work out good for our supervisor is in our calendar at work, we have to put down our where we're going to be that day. And internally in that message, we put down who we're going to see, their phone number, the address we're going to be at, and then that's all in there. So should he ever wonder where we really are, he also comes out on the road and does supervision. But he can also go into that person's name and see the note that we wrote about the interaction that day and where we were and what we talked about, and just kind of coordinate that so you know where your people are, what they're doing that day, and what they had done the day before. That helps.
Thanks, Karen. Valerie?
I was going to say too, like, if you can think of yourself as equals when you're doing your supervision. So maybe you have an MSW. I have a peer support specialist background, but we're not any different. And being able to learn from each other. So even using that intentional peer support model of like, what can I learn from you? What can you learn from me? And having that collaborative approach makes it a little bit easier when it comes to supervision.
So we do have some places also in the country where they do co-supervision, where you will be supervised by a clinician and a person who's been trained to supervise peers. We have models where some behavioral health systems will hire people who are in peer roles from a recovery community organization or a peer-run organization, so that they provide the supervision, although the person is working within a behavioral health system. So there are different kind of models out there. There is more information. If you want to sign up, we can certainly, there's tons of information on supervision of peers that also can be shared. All right, we have another question. Let me see.
So I just want to piggyback on what Caroline says about managing peers in a traditional system. I work in a DA in Vermont as a peer, and I'm managed by a peer. And what I find that works is having the people at the top buy into the values. So we have trickle down, right? So like if the top people that sit at that senior leadership, the big table, get paid the big bucks, if they don't value peer support, anybody beneath them isn't, because it's going to roll down. So allowing peers to sit at, or to make policy, or to be at the table with other people, just having supervisors is not enough. They need to be embedded in your senior leadership team. They need to go up. If you don't have peers at the top, or at least people that buy into it, you won't have an effective workforce underneath, or people that believe in it.
Yeah, I think totally understanding that there's different approaches and that they should be valued. So for example, you know, when I was in a peer role at a hospital, like the psychiatrist's approach, for example, if someone was hearing voices, was to give that a diagnosis and try to use like an anti-dopaminergic to silence it, you know, sometimes with very little effect. That's one discipline. You know, for me, my approach was to ask the person more about their experience with the voice. The voice had a gender, a name, like, could they have like a conversation with the voice? When was the voice louder? Not, you know, for me, it wasn't to define the issue. It was just to explore more about it. And what we need to see are environments where one of these approaches is not like held like head and shoulders above the rest, where both are respected.
Thanks. Anyone else on the panel? Go ahead, Karen.
At Beacon, we're very, very lucky. Our CEO, Lori, has even invited peers to testify at the legislative hearings, at budget hearings, because she knows that works. So we're very lucky to have that.
We do know a lot of work from the recovery movement about the importance of having people with lived experience at all levels of decision making in an organization. So I just want to echo that principle. Sarah?
So I mentioned power when we first started, and I'm not hearing anyone, with the exception of Caroline, talking about power. And even in Larry, your remarks earlier, you talked about the transition being the risk time. Actually, the risk is elevated even while someone's in the hospital. As we sit here, a friend of mine is with her son in the hospital around suicide risk because DCF threatened to take him out of her custody if she didn't consent to that, even though that was not what either of them wanted. And that is the sort of thing that is happening everywhere. People are wanting to die often because of powerlessness, and the system is often doing that to them. And so I guess I wonder if we can hear more about people's take on powerlessness that comes from being diagnosed, from being forced into the system, from being referred to as client, from having drugs pushed on people, all of these things that research tells us and our lives tell us are a problem that we're just not really hearing in this conversation too much.
Valerie?
So I can say, like, within our groups, because we are peers living with similar challenges, but we're not more recovered, we might share some insight about what might work for us, but not pushing it on some, like giving them the power to decide what they want to do and not coerce them to go to the hospital or coerce them to any kind of treatment or take medication. We don't even actually talk about specific medication, and we always say, you know, use your eyes. If you want to talk about maybe medication worked for you, but not that you have to use this type of medication, and kind of also keeping people out of the hospital, being able to say, like, you have the power within you, and talking about it and being here is a sense of power, and facing that stigma, you're breaking that stigma by being able to be here and do whatever you need to do to work on yourself. I hope that helps a little bit.
I mean, again, this is also the beginning of a conversation, right? So that, you know, that's something we need to focus on again, and maybe we need to have more people from some of these big systems here to have some of that discussion. You know, how do we address the power differential? What does that look like? I have one comment and then one last question before we go to the next piece.
One thing we try to do with any members we have is to help them self-advocate for themselves, and like was just said, to help them what they want, what they think, what they know themselves better than we do, what will work to get them through. So a lot of times we'll go to the discharge meetings at hospitals so they make sure that they are going to what they will go to, not something that's shoved on them and that they're just saying yes to get discharged. So I hope that's kind of a power control thing. They can accept something and not accept it and offer alternatives, like even, you know, a gym or yoga or something. It doesn't always have to be intensive outpatient, 5 days a week, that kind of thing.
I feel that I would be really remiss in not saying that I think these power differentials harm people on both sides. I I know there are a lot of clinicians struggling. We haven't talked about the high rates of suicide among doctors here yet. Very few people that I've met through the RLC, through Alternatives to Suicide groups, end up dying by suicide. It's very different than when I worked in the system. But there have been a couple, and one of the things these people had in common was they worked in clinical roles in the mental health system, in the Western medical model, where a lot of them were expected to wear sort of this mask, not disclose a lot of their own struggles, where they were expected to take control over people, use power over people, when they knew deep in their hearts that wasn't their why. That wasn't why they were doing this work. They came into this work to build relationship and understanding and healing, and then they were being told they had this other job. So, I am not a clinician. I've never worked in a clinical role, but I've shared space with people who have that are struggling deeply. And so I feel like I also want to uplift that voice, because people may be here feeling that way, but unable to express that.
Thank you. One last question.
Thank you. Sometimes I'm caught between roles of, I work at the state level and working between funding between the CDC and SAMHSA, where to me, they don't feel like they're on the same page. Because one's in a treatment role, one's looking at different things, and I hear a lot about the social determinants of health and how where you live affects the things that you do. And you brought up the talk about having a living wage. Mm-hmm. And when we think about transportation and being able to get to an appointment and missing 3 visits, and now you have to find a whole new doctor because you missed those, and having a place to live. And so all those social and environmental determinants of health, those are things that one agency is looking for, but the other agency is not looking at that because it's more on the treatment side of things. And so, I appreciate the fact that you talk about having a living wage, because it is incredibly important. And looking at the whole picture of incidents of looking at how those things like a living wage and empowerment programs, especially empowerment for programs for like women of color and things like that, and how you can affect sexual violence, intimate partner violence, all these other issues that could lead someone down the path of thinking, gosh, I don't want to be here. And how, so when I think about we have these community health worker programs where we have folks going out in teams going to do this, and how can this peer model be the same? How can we look at parity when we don't think about looking at peers in a mental health sense the same way that we do in a health sense? And how, if there are ideas and ways that we can model that, to take that in a sense of having these peers. For me, to take that back at the state level and say, how can we support that? Because we're supporting community health workers, but how can we either integrate peer mental health into either the community health teams, or have this whole other set of teams that are going out and looking at these social environmental determinants of health in the communities, what's affecting people in all of these other ways that ultimately impacts their lives in these very profound ways.
Peer roles done right are always looking at those factors. A peer role is one where there is not a focus on diagnostics or individual pathology. We're looking at the richness of our own narrative and all the factors involved, in our own language for distress. So I think, folks in peer roles, that are well-versed in peer values are well-equipped for some of those conversations, because they're not necessarily looking for what's the biomarker here.
All right, I am going to thank our panelists very much. We're a few minutes over, but I really appreciate you and for sharing. And please give our panelists a hand.